the next talk, and that will be by Dr. Divya Srikumaran, and she will be talking about cataract surgery in patients with corneal ectasia.
Good evening. Thank you so much for the invitation to speak today. My name is Divya Srikumaran, and I'm excited to join you all. So I've been asked to discuss, these are my financial disclosures, and I've been asked to discuss cataract surgery in eyes with keratoconus, a problem that we're likely to see more often. So as we know, keratoconus is a bilateral non-inflammatory disease of the cornea characterized by progressive thinning and myopia. The prevalence is about 1 to 2 in 1,000, and treatments include glasses, contact lenses, intrastromal rings, keratoplasty, and then more recently corneal cross-linking, as well as topoguided PRK. Several studies, including our own, have shown that keratoplasty rates for keratoconus have been decreasing over the last decade. And this is in part due to the availability of advanced contact lens technology, as well as corneal collagen cross-linking. And so what this means is that we're likely, as we continue to practice, to see more patients with keratoconus that require cataract surgery that have not had prior keratoplasty. So there are several special considerations that I'd like to review today when it comes to performing cataract surgery in patients with keratoconus. One is to determine whether the visual symptoms are related to the cataract or the cornea, or possibly both. The other relates to IOL measurements, the calculations, and the choice of the IOL that's implanted. And then finally, intraoperative considerations such as wound construction. So this algorithm may be helpful in deciding how to approach patients and determining how to handle patients that have both keratoconus and cataracts. So the first thing is to try to determine the cause of the visual symptoms. In a patient that has progressive keratoconus and no visually significant cataract, then treatment of keratoconus is indicated, and that might include corneal cross-linking, intrastromal ring segments, keratoplasty, or contact lens fitting. In patients that have visually significant cataracts and stable keratoconus, then cataract surgery would be likely performed. Whereas patients with advanced keratoconus and cataract both contributing to the visual loss, one might consider staged procedures with either intrastromal ring segments or keratoplasty first, or combined at the time of cataract surgery. So in terms of determining the difference, serial topography can be helpful in determining whether or not the keratoconus is progressive. Age is also a helpful clue. Patients that have myopic refractive shift with stable topography likely have cataract progression, whereas patients that have significant corneal scarring and or hydrops, as seen on this OCT image, may have symptoms from their keratoconus progressing. Patients that have advanced ectasia and that are contact lens intolerant would also need treatment for their cornea in addition to the cataract. So let's take an example here. This is a 58-year-old artist who presents with difficulty with color vision, ghost imaging, monocular diplopia. She's no longer able to get good glasses, a complaint I think we all have seen before. Her best spectacle corrected visual acuity was 20/30 in the right eye, 20/50 in the left eye. Her cornea is mostly clear with the exception of an iron line, and she has 2+ nuclear sclerosis. Here on her tomography, you can see that she does have some steep keratometry readings inferiorly, but they're relatively mild. Her most steep K is like 47 inferiorly. So in this patient, her age at 58 makes progression of keratoconus less likely. And again, the keratoconus is mild. We did do an RGP over refraction, and her vision was only 20/40 in the left eye, and she had persistent ghosting. This suggests that possibly the cataract is the primary cause of her visual symptoms. So we proceeded with cataract surgery with a monofocal lens implant, and thankfully she's doing well. Her vision improved to 20/25, and she is no longer experiencing the ghosting that was once troubling her. So biometry in patients with keratoconus can be quite challenging. Usually a contact lens holiday for 2 to 3 weeks or more prior to biometry is recommended, depending on the degree and length of contact lens wear. Patients with advanced keratoconus can have poor fixation, which makes biometry more challenging as well. And then finally, there is significant variability. Both manual, optical, and tomographic keratometry readings should be obtained to try to compare. It has been shown that in mild to moderate keratoconus, the tomography readings tend to be more accurate and reliable compared to optical biometry, and optical biometry tends to overestimate true keratometry. So here's an example, and you can see that the optical biometer had found here Ks that were in the flat K was 39.62 and the steep K was 43.95. The mean K is around 41.79. And here from a pentacam, you can see that the EKR 65 4mm zone, that the Ks are quite different. And this also raises a concern with regards to placing toric lenses and how much astigmatism to treat. If optical biometry is used and you treated this patient with 4 diopters of astigmatism, the net effect on their cornea, especially in the central cornea, is quite different. It makes it difficult to determine what to aim for and what to target. With respect to IOL calculations, we also find that patients with keratoconus have longer axial lengths, deeper anterior chambers, and this leads to an inaccurate estimate of the effective lens position. The apex is oftentimes not the central visual axis, which again skews, if you look for the steepest keratometry, the corneal power that would affect the patient's ultimate refraction. Optical biometry, as I mentioned earlier, tends to overestimate corneal power. And all of this, in sum, tends to lead to hyperopic errors. So several studies have been trying to evaluate which formula might be most accurate in these eyes. This recent review from 2020 in JCRS had suggested, after a review of over 19 studies, the SRKT formula would appear to be the most accurate with the least hyperopic errors. We had done an analysis of cases at Wilmer and found that in our series, for patients with stage 1 and stage 2, the Barrett Universal 2 formula was actually most accurate. Here's another study by Dr. Kane and colleagues, and they looked at 147 eyes, and they found that the Kane keratoconus modified formula was the most accurate, followed by the SRKT for their cohort. This is a slide or a figure from their paper, and what you can see is whereas in normal eyes we tend to get 80% of eyes within 0.5 diopters, in patients with keratoconus that's about 50%. So we have a long way to go in terms of improving our refractive accuracy with this group. In terms of power selection, some recommendations for from Dr. Kane's group suggest that to avoid hyperopic outcomes, if you use SRKT formula, you should adjust and target more mild to moderate myopia. So in stage 1 disease, where the keratometry steep K is less than 48, no adjustment is required. However, in stage 2 disease, where keratometry is between 48 and 53 diopters, aim a little slightly more myopic, minus 0.75 to minus 1.5. And then in more severe disease, where the Ks are over 53, aim minus 2 to 3 diopters more myopic relative to your target to try to avoid the hyperopic surprise. In general, myopic errors are better tolerated and easier to treat with contact lenses than are hyperopic errors. So with respect to lens type, this depends on the severity and the regularity of the astigmatism and the use of contacts. So monofocal lenses will not interfere with the ability for the patient to have subsequent keratoplasty or contact lens wear. So if it's determined at the time of the cataract evaluation that the patient is going to continue to wear contacts or would prefer to wear contacts to achieve their best visual correction or might likely need keratoplasty, a monofocal lens would be far preferred over a toric lens. In patients that have keratoconus, presbyopia correcting lenses, in my opinion, should be avoided due to the higher order aberrations, although some reports have suggested that reasonable outcomes can be obtained. Toric lenses have also been described in limited case series, and they do show a reduction in astigmatism in eyes with stable and regular astigmatism. However, toric lens use in eyes with keratoconus is off-label and it requires appropriate counseling. I'd like to share with you an example here of a patient I had recently seen for a second opinion. This was a 58-year-old unhappy patient with uncomplicated cataract surgery with toric IOLs. She had a history of spectacle-corrected keratoconus, and she developed significant starburst and difficulty in driving at night since her cataract surgery. If you look here at her results, 20/30 uncorrected in the right eye, 20/40 uncorrected in the left eye, it seems by all accounts a successful outcome. The degree of astigmatism is quite low, less than half a diopter, but she's still quite symptomatic and unhappy. And remember, these are highly aberrated corneas, and we're inserting a lens which may not fully treat their pathology. So you can see in her topography, while it seems as though her central cornea might have some irregular astigmatism, especially in the right eye, you can see that the variability from the superior cornea to the inferior cornea is quite substantial in terms of her keratometry readings. And in the left eye, frankly, the whole central cornea seems highly aberrated. And so it's not a surprise that this patient is not happy with her symptoms at this point. So the future for keratoconus patients may include the use of a pinhole IOL. This is a recent study in which they had 17 eyes with highly irregular corneas. 8 of these eyes had keratoconus. These were patients that had mild early cataracts. So the cataracts were not felt to be visually significant. The pinhole lens implanted did improve in their corrected distance visual acuity in 16 out of 17 eyes, suggesting that the pinhole effect may have improved their overall visual acuity. Last point that I wanted to raise was just about intraoperative considerations. So these are very soft, pliable corneas, and so wound construction requires significant consideration. Consider avoiding areas that are thin, placing a suture, possibly a scleral tunnel. These corneas can be scarred, so trypan blue can be helpful, especially in the setting of intacts or highly irregular cornea scoring. OVD on the surface can sometimes improve the view. And then finally, the role of intraoperative aberrometry is still unclear and more data is needed. So in summary, determine if the cataract or the cornea is accounting for the visual symptoms. Optical biometry overestimates corneal power. There's a tendency for hyperopic errors, so aim for more myopia. And then again, there's no consensus on the ideal formula. Consider both the Barrett or the SRKT and look at the Pentacam keratometry. Toric lenses may be used, but with caution, and then low threshold to suture the wounds. Thank you so much for having me and for the opportunity to speak.